and welcome to our live stream. Our patient is having back pain, and he has back pain from AP. 11 different sources. 11. 2 discs, 6 facet joints, 2 piriformis muscles, and 1 SI joint. I think that makes 11, doesn't it? He also has some scoliosis. Yep. Let's go to a lateral, please. You can see that giant facet joint there. So we're going to be treating all 11 sources today. We're going to break this up into 3 separate live streams. We'll start with his discs. All right. He is resting comfortably. Let's see if we can get into this disc. 5-1 shot. Shot. And sometimes we can't make it into a disc because of anatomical problems like we're sort of experiencing here. Shot. All right. Give me have a AP. Shot. Give me an AP. Now, I think you're off on orbit. First thing we're going to do is get to the 2 discs we're going to fix, which may not be possible. Let's see. Stay there. Shot. All right, let's go with the lateral. This L4-S1, because the spine is tilted and there's a giant facet joint and a large transverse process. It's going to be an interesting one to try to get to. Huh. I'm just hitting that bone spur. Yeah, it's no way around it. Interesting. Give me an AP. Again, I think you're off on orbit a little bit. But let's see where we are on AP. See that bone spur? Show us the bone spur. I'm going to try to come from a little more lateral. Sometimes that works. Shot. That's our only hope, is coming more lateral. But I'm still hitting that same bone spur. AP. 5-1 may not be achievable. Let's see the MRI. Yep, still hitting the same exact spot. Shot. Lateral. No, this bone spur is just huge. There's a tiny little window just to get in, and I can't get past it. It's bound by the iliac crest, the transverse process, and the facet. And there's just not happening. Shot? Let's go to 4-5. Shot? Try to get that lined up properly. Yeah, it's better. But look, let's try to go a little more north. So unable to access L4-S1. Guys, for DLDR. Unable to access L4-S1 due to abnormal anatomy. Jordan, you're off on the rabbit ears, dude. Come on. You're off on WAG and you're off on... Your orbit's okay. It's your WAG that's off. Shot? I think that's... I don't know. Does that look better? Try the other way. I think that's worse. Yeah, he's got scoliosis, so you're going to have to accommodate it. Shot? Is it? I'm not so sure it's worse. Let me release the wag. Shot. 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 That looks better to me. You're off on orbit. More. Is it? Yeah, it is worse. Try the other way. That's better. That's good. That's as good as we're probably going to get. So let's keep it there. Shot. Man, I'm hitting bone again. Amazing. Shot. I think I can get around this one though. Good. Give me an AP. Oh, he's a mess. But you see that dark area at 5-1? That giant, that's an enlarged facet joint. It's literally blocking my ability to get in. Shot. Is he awake?
How are you? You all right? Open your eyes for me. How are you? You okay?
Kind of hitting the top of the
We're gonna ask you some
shot.
questions. He's waking up nicely.
I may just want to put him back to sleep.
Okay.
Let's see. Hold on.
A little bit too, right?
Hmm?
Might relax him a little bit to go back to sleep.
Shot. Fascinating. Definitely in the right spot. And it's 4-5. I'm just having trouble getting into the disc. Shot. Interesting. All right. We can put him to sleep. I can't do a discogram. I mean, I'm right on the end plate. I don't think we're going to get a discogram shot. Yeah. It's just leaking out to the side. Because his spine is twisted and he has enlarged facet joints, it's made it very difficult to get to the discs. For what? Unable to do discogram due to anatomical constraints. It's the same thing. Unable to get to 5-1. You have any numbing medicine? All right. Henry, let's show our audience, shot, how is it that these disc herniations in the lower back can cause so much pain? Okay, welcome back. You understand how these discs cause so much pain. Well, there it is. Look at that pink tissue. That's the inflammatory tissue. You just saw it on your video. That's what we're here to clean out. That's where the pain comes from. So,
We have a question.
sure.
This comes from Georgios on Facebook.
Hello, Georgios.
They ask, hello, Dr. Duke. How do you direct the dilator into the annulus, ensuring you don't hit any nerves?
That's a great question. That is the hard part of the surgery, isn't it? So the key is to place the spinal needle properly with the patient, number one, that they're awake, so that they're going to tell me if I'm too close to the nerve. They're going to complain about pain going down their leg. Second of all, I know my anatomy very well. And I studied hard, learned my anatomy. I know exactly where everything is. And I make sure that I use my X-ray machine to navigate the needle to the right spot through the right area. So it's kind of like sailing a ship through a reef, right? Around an island. Remember the pirates of the Caribbean? Those pirates used to rob the merchant vessels from the French and English and Dutch. And they would go and rob the vessels, and then they would be chased by the British Navy or the French Navy or the Dutch Navy, and they would then navigate around the reefs of the islands. And they knew exactly where the reefs were, where they were shallow, where they were deep. They mapped it. And the reefs don't change. And the same thing with humans. Our spines are built very similar. So if you understand the anatomy, you understand it's like reading a map and knowing a map of an area. You understand the underwater terrain. That's how the pirates were able to evade the British for so long, because they used their knowledge of the reefs to cause the British to crash their boats while they were pursuing the pirates, or to just stay away from them. So we use anatomy like a map of an island's reefs. We know exactly where the danger areas are and stay away from them. And I use my X-ray machine to look at the anatomy. So just as a sailor would look at the land, the island, they would look at trees, mountains, rocks, beaches, contours, shapes, right? And they would take that information and they would use it to make a determination of where to go with their boat to avoid hitting the reef and dying, or being captured by the British Navy and being executed in front of everybody. So we use our X-ray machine for navigation and localization. I hope that's a satisfactory answer for you, Georgios. Next question.
Next question comes from Georgios, once more on Facebook, saying, Dr. Duke, I am very impressed with your live streamings. I notice you hammer the retractor. What are you hammering into?
We're hammering, so we're placing the tube inside the disc. You see this material here? This is the herniation. And it's not like a fresh herniation, it's an old herniation. It's scarred, so it's very hard, it's stiff, and the only way to get the tube in is to hammer it. Now, I could use another method. I could push hard, but what happens if I push hard and then suddenly it gives way? Then the tube will end up in the patient's bladder or their intestines, and that would be really bad. So rather than pushing with my hands, we use a hammer. A hammer allows the surgeon to deliver a very, specific amount of energy or force to the tool. And it allows me to drive it forward, gradually. Now, of course, I'm not hammering it like you hammer a nail into a roof, I'm actually feeling every hit, and I'm feeling these are all big pieces of herniation. I'm feeling the tube slide forward. So it's not the same as hammering a nail or something, but it's kind of the same. Look at this herniation. There it is. We got it. Oh yeah, look at that thing. You see it?
Yes, we do.
Bam. That's a pretty good one. 2 centimeters. Dr. Davis, slather it in butter and throw it on a bun. Brett, get the barbecue sauce. That's how we do it down here in the South.
Yellowfin tuna.
Minus the fin.
Not for sushi.
Wow. I don't know that we're done. All right. Again, more pieces. So people think that a herniated disc is a herniated disc. It's one herniation, but it's not. It's actually many pieces, usually in my estimate around 30 pieces of herniation. By the way, the scope use on the last patient was a 6. You got to be asking me that stuff. How are you going to get the numbers otherwise? Huh? Don't make me write you up. Next time, write up. Any more questions?
Oh, we just got a question from Rich on YouTube asking Dr. Deuk, what about lumbar lordosis slash straightening of the lumbar lordosis? What procedure would you recommend for that?
Great question. There is no procedure needed for straightening of lumbar lordosis. What you're probably referring to, we call it flat back deformity. That is not causing your symptoms. You don't need it treated. But if you want to straighten a spine, if you want to take a straight spine in the lower back and make it curved, then you have to add cages, but it gets more complicated than that. First of all, I am not recommending this for you, okay? Make that very clear. But if you want to correct a flat back deformity in somebody surgically, the surgery is the best way to do it, but the best surgery is to do what's called Smith-Peterson osteotomies, okay? There's another piece of herniation. Look at the red color. You guys see the inflammation? We
Yes,
just
we do.
showed you a video on how the herniated disc causes inflammation. The inflammation is red. If you look at the video, it's pinkish red. That's because it's got a lot of blood supply. Same as a zit on your face. Any kind of inflammation in your body has a lot of blood supply, so it turns red. That's what we're seeing. Normally the disc is white, but this is red. So the best way to correct a flat back deformity, if you're going to do it, and I'm not recommending this because I don't think you need it, is to do first Smith-Peterson osteotomies. Remove the abnormal facet joints. You saw the facet joint on this patient. It's big. It's about 4 times bigger than normal. Okay? And that comes from a process called hypertrophy, and another name for it is arthropathy. Hypertrophy is enlargement. Arthropathy is an abnormality of the joint. Hypertrophy is part of arthropathy, but not all of it. So arthropathy has other things that are part of it, but this patient has facet joint arthropathy, and that's causing his pain as well. So we're treating his facet joint arthropathy, his discs, his piriformis muscles, and his sacroiliac joint. All of them are contributing to his pain. But to get back to the flat back deformity, the first thing I do is a Smith-Peterson osteotomy on both sides. Remove the abnormally enlarged facets that are not going to want to move otherwise. And then you can actually reduce the curvature from being flat into being lordotic, which is what you're supposed to have. And you can do that by placing interbody cages. So the best way to do it is to go posterior through the back, do a laminectomy for decompression, because you need that done. There's a reason why you have a flat back deformity, and it's because your nerve roots are being pinched from spinal stenosis. Then I would do a Smith-Peterson osteotomy. Then I would do a interbody cage and reconstruct your anterior column and middle column using cages as big as possible through a posterior approach, usually a T-lift. And then I would put in some screws and rods, and if I needed more lordosis or deformity correction, then I would just put in excessively contoured rods that are more bent than your spine, and I would reduce the spine to the rod using a reducer. I would do all of this on a Jackson spinal table so that you have the benefit of the table helping use your weight and gravity to reduce your spine into lordosis. So it's a very complex surgery. It has to be done just right. You need a Jackson spinal table, you need a Smith-Peterson osteotomy, you need a laminectomy for decompression, and you need interbody cages, and you need pedicle screw rod fixation that's segmental and bilateral. That's how I would do it. But again, you don't need any of that if you have this surgery done, because we can fix the pain without doing all that. Next question.
At this moment, no current questions.
All right.
We did just get a comment from Rich P on YouTube once more saying spine started straightening after laminectomy procedure with Coflex devices.
Yeah, that's why we don't do the Coflex, because it causes the spine to go with a reverse curve. Listen, come to Deuk Spine, we'll fix you, but you're not going to need a major surgery most likely. My advice is get your MRI to me, do a free MRI review. Let me see what's causing your symptoms, and I'll tell you how to fix it, okay? But I can fix your spine. I can make it feel better. You want to go back to feeling normal? We can do that at Deuk Spine. Your best chance is at Deuk Spine. Don't go anywhere else. They're going to screw you up. You like that, Davis? Screw you up? Screws going up the spine.
Screw you up as
Yeah.
in putting screws in your spine.
Yeah, screwed up. This guy is an example of exactly what I preach about every single time I get online. Okay, these doctors, they start with a minor procedure, the epidurals, the shots, the RFAs. They milking the money, getting the money. Lots of little payments at first. The patients get a little addicted to the treatment. They come back, they get a laminectomy. They get like a bunch of little more procedures, all treating the same problem that never was treated properly in the first place. And then they get a fusion, and then they get another fusion, then they get more laminectomy, more pain management, and then finally they get more fusion, and then they get a stimulator. And by the time these guys are done with you, they would have made $1 million off you, your insurance. So forget about all that. They're using you for your insurance policy most likely, or the money. Just come to Deuk Spine. We'll fix you with one procedure, one and done. As long as you have all the pain you normally have, I can figure out where it's coming from. Okay? As long as your pain is there when I see you and examine you, then I'll know where it's coming from. I'll tell you where it's coming from, and you can get fixed with a minimally invasive procedure. You don't need all that jazz. We used to do that for our patients. Fusions, laminectomies, pain management, not because we were trying to milk them, but because there was no better way to fix them. It was just those treatments, and they sucked. But now we actually have curative treatments that we pioneered. So we want our patients to be cured. We don't want them coming back. All right, you guys saw that pink tissue I just zapped away there, Henry? That was the inflammatory tissue. Have you run the video on how the Deuk laser disc repair works?
Not yet.
Let's do that so you can see.
Copy that.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Dr. Davis said for me to show you guys where the end plates are. There's an end plate right up there at 1 o'clock, now 12 o'clock. That's bone. You guys see the bone right there? That's the end plate of the vertebral body.
Yes, we do.
We're at the back of that L4-5 disc. We're cleaning out the last of the herniation. Any questions for me?
Yes, this next question comes from, forgive me, I'm mispronouncing this, Lonika on Facebook.
Hello, Lanika on Facebook. Welcome.
Asking, please tell us what is happening in the live view.
Okay, there's a laser right there, the blue thing, and there's a glass fiber coming out of the blue, which is, the blue is a protective coating of plastic, and the laser fiber is clear, and it's made out of glass, and it's transmitting energy from a giant machine in the operating room, a laser machine, that produces laser energy. And then it's transmitting it from that machine over here to where I'm working under the scope, which is this herniated disc. And it's breaking it up into little pieces so I can get rid of it. It's called vaporization. All right, we're just about done. So, Henry, you're going to end the stream, and we're going to
Yes.
come back with the facets.
Yes,
And the SI joint.
correct.
So save the questions. Folks, we're going to end the stream, and we're going to restart it again for the SI joint and the facet joint and the SI joint on the right side. All right? And go ahead, and you can end the stream now because we're pretty much done here.
Copy that.